Wonderful. So if we could have the speakers from this morning's second session come up, write your questions down on your cards for the panelists relevant to their topic areas, and then we'll go from there. We'll have people pick up cards, or if you want to grab a microphone, either way. So there's a question regarding active surveillance. Maybe this is for you, Dan. Is there a role for dutasteride in active surveillance?
So it's a great question. Dutasteride is one of those medications that traditionally is approved for shrinking the prostate for symptoms. So it's approved for men that have a prostate that's enlarged and that is compressing on their urethra, so they're having symptoms of, as we said before, getting up at night, slow stream and so forth. So the simple answer is that the FDA looked at the data because there was a trial where they gave men on active surveillance dutasteride or placebo, and it did show that in the men that received dutasteride, there was less men eventually having surgery, maybe less men having the finding of high-grade cancer. The company went to the FDA and said, okay, approve this for that purpose. And they looked at all the data, and they actually said no. There was one reason why, is because there is a bit of suspicion that those medications, it shows that those medications might be able to prevent prostate cancer in general, but it shows that the men that get prostate cancer taking those medications might have slightly worse prostate cancer. So there's actually a black box on dutasteride and finasteride saying that before you start a man on that anyway, you should make sure they don't have prostate cancer. So it was promising, but it didn't work out. So we don't give dutasteride for the treatment of men on active surveillance. There's plenty of my patients and the other urologists in the room that have men that are on active surveillance that have other symptoms due to enlarged prostate, and we give it those for that, but not for the treatment of prostate.
A couple more questions for Dr. Lin. Where in Seattle is MRI Fusion targeted biopsy done?
Yeah, so we had the first machine in really, I think, the 5-state region in the Northwest for a while. I'm pretty sure that there's a couple of the machines in Seattle. I don't know precisely. I'm pretty sure there's one more in Seattle. I know there's one in Spokane. There's one in Anchorage. Okay, but the University of Washington was the first place and still probably has the highest volume.
And the last one for you. Do most urologists know about PCA3, or where would somebody get access to the urine test for PCA3?
I think most urologists do know about PCA3. Has been around for many years now, and even some primary care providers know about PCA3. It's a simple digital rectal examination and then a urine sample. So most are very well aware of it now, and it is covered by insurance only in the setting of a previous negative biopsy. So not just in the elevated PSA, but having had a previous biopsy. So
this question may be more relevant for Evan and Mike Schweitzer. I think this is related to advanced disease, but the question is, there's a concern that biopsy has material risk in causing complications. So this would probably both localized prostate cancer as well as these metastatic lesions. We're talking about more precision medicine. So maybe Evan, do you want to say anything about complications for metastasis biopsies, and then Dan, think about localized disease?
Yeah, I think there's two potential risks that might be concerned. One is just the risk of biopsy, meaning bleeding, infection. Those are a potential risk anytime you stick a needle in somebody. And we've been fortunate; we really haven't seen that as a major complication here in our center. But of course, there always is a minuscule risk. As I mentioned in my talk, there's no free lunch in life, so there's always a tiny risk. I think the other thing that people sometimes talk about is spreading the cancer potentially, and we really have not seen that in the field of prostate cancer. There are some other cancers that we have some concern of, and I think this is a chance to emphasize that not all cancers are created equal, but that's just something that we haven't seen.
And Dr. Lin, go ahead. Dr. Lin, what do you think about repeat prostate biopsies over time, like for active surveillance? Any issues with the first one or repeat?
I think the easy answer is no. We've looked at those data to see whether placing a needle through the rectum, you think you're placing a needle through the rectum into a cancerous gland, you would drag seed or sort of make spread. But we've looked at that and we haven't seen any evidence that it shows any undue harm. I will say that biopsies, prostate biopsies, about a 1% chance of having bleeding event, about a 1% chance of having infection. What's probably more than that is men get antibiotics and they might breed resistant organisms. And so there is something that we pause and we think about that. If we go through the skin transperineally, there is not that issue of infection. So that's one of the arguments about that type of biopsy. And I know in Australia, they basically do all their biopsies through the skin, not through the rectum.
So this question is related to the liquid tumor biopsy, Dr. Schweizer. So the question is, since most blood draws are obtained through the arm, where is this type of blood draw obtained for a liquid tumor biopsy?
Yeah, it's still through the arm. It's the exact same procedure as, getting your PSA checked. It's basically just drawing blood, because the idea is that if there's tumor cells or DNA from the tumor that's circulating, it's going to go everywhere. So there's no need to do anything more invasive to access that blood compared to, the blood you need for a normal standard test. So that's one of the big advantages, I think.
Dr. Yu, could you explain again what the PSMA PET scan actually is?
Yeah, so a PET scan is just the machine, but the reason you can image all different things, I said metabolic, molecular, is that you basically take a radionuclide, and there's different types, that you attach it to something, okay? And the most simple imaging is just fluoride, for instance. It's just F-, and that just incorporates into the bone because you have hydroxyapatite in the bone, and it displaces a hydroxyl group on the bone and goes there. But most of these are attached to something. So the PSMA imaging is often attached to an antibody that recognizes PSMA. Okay, so it depends on what you inject in. The machine just takes a picture of that. So that's the way to think about that.
Yeah. So one way to think about it, so PSA, you think about prostate-specific antigen, it's very prostate-specific, but it's secreted out of the cell into the bloodstream. So it's no longer stuck to the tumor cell. PSMA is relatively prostate-specific, and it stays on the surface of a tumor cell. So it acts like a little beacon that you can try to recognize with an antibody that might be labeled to a tracer that you can image. So, Dr. Swanson.
Question for Dr. Yu. When do you think gamma-68 PSMA lutetium-177 might be available in the United States for treatment? And if it does become available for treatment, based on the European experience, how effective do you think it might be in metastatic prostate cancer?
So maybe remind them what it is.
So, okay, so I think you brought up two different types when I talked about the end. One is the lutetium that targets PSMA treatment, and that's a beta-emitting radiopharmaceutical. It does have more spread. So, for instance, if it goes to the bone, it does have higher risk of myelosuppression. It's been generally used more for patients who have advanced disease, more targets to go after. But the concerns there is that you could, when I say myelosuppression, again, that's lowering of the blood counts, white blood cell, red blood cell counts. That is not widely available right now. It is right now under investigation. New drug contract are allowed to be done in a certain place in New York. But we are working with them to bring that here potentially within the next year. To be able to do that sort of treatment here. So that's part of a potential collaboration that's upcoming. So again, it's not widely available, it's not FDA approved treatment, but under research studies, hopefully in about a year or so, we should hopefully have that here. With the other compound, the actinium one, that is the alpha-emitting radiopharmaceutical, the one that's more targeted, more focused, doesn't spread as much, but the one that hits the salivary gland. So that right now is being used in Germany, but again, it's being used in pretty advanced stage patients because the concerns of taking away your ability to salivate.
Thank you.
Last question here, and then we'll break for lunch. Right there. Oh, you have...
Okay, splice variant. I found that very interesting. I'm not sure exactly what causes it. Lupron is one of the treatments, and bipolar antigen treatment is another theory. What effect do those two have on splice variants?
Yeah, so, I mean, what causes them, I don't think we really fully understand right now. There are some cases when you can see that the DNA that encodes the androgen receptor is altered, but probably in most cases it's actually the RNA, that sort of messenger to go from the DNA to a protein, gets flip-flopped around and it loses that that end part of the androgen receptor. Okay. We see that when patients receive more lines of hormonal therapy, the prevalence of the splice variants go up. So after a guy gets Lupron, the incidence of splice variants is very low, but after they received Lupron plus abiraterone plus enzalutamide, it goes up and up and up. Okay. So, as far as the impact, I think, of hormone therapies, we basically see that they select for these splice variants, okay? Now, the idea of high-dose testosterone is bipolar androgen therapy. One of the things that we've noticed in studying that is when you use high doses of testosterone, it's kind of opposite to the way we approach treating prostate cancer at early stages, right? And you can actually see that in a reasonable number of patients, and also in prostate cancer cell lines, that you can make the splice variants go away. And so far, in the handful of patients we've actually been able to demonstrate this, the splice variants do look like they come back after you stop treating with testosterone, but at least transiently, it looks like they're able to suppress them. And there are ongoing studies to try to see whether or not this would be an effective strategy for treating guys that have the splice variants as well. But I think, it's certainly a compelling rationale for trying testosterone in those patients. So.
Excellent. So feel free to jump and ask these guys additional questions during the break. We're going to break for lunch now.